Right, let's get going. My name is Bob Wiggins. As I say, I'm chair of Give a Kidney. I'd like to welcome you to this, our Ask the Experts webinar. This is the second one that we've held in the last 2 years, and it's usually got a very good response. It gives you a chance to ask a panel of experts, all things related to living kidney donation and transplantation. So this is your opportunity to ask those questions that you haven't asked others already, or to get a different perspective, perhaps on questions you have already asked. This webinar is recorded. We will be posting this up on YouTube for benefit of people that are unable to attend this morning. Use the Q&A function to ask your questions. I'm joined by Jan Shorik, our Executive Officer, who's going to moderate the session today. And without any other delay, I'd like to introduce you to our panel. And perhaps each of our panelists could introduce themselves and their role and relationship to kidney transplantation. So if I could start with Adnan.
Good morning, everyone. My name's Adnan Sharif. I work in Birmingham, and I'm a nephrologist, so I'm a kidney specialist from a medical point of view.
And Frank.
Good morning, I'm Frank Dora. I work in the Hammersmith Hospital, Imperial College in London, and I'm a transplant surgeon. I'm very passionate about living donation.
Lisa.
Thanks, Bob. Hello, I'm Lisa Bernat. I'm a consultant nurse by background and I've worked what feels like most of my life with living donor kidney transplant donors. I'm the Associate Director for Living Donation and Transplantation within NHS Blood and Transplant. It's a great pleasure to be with you today.
And Paul.
Hello, I'm Paul Vanden Bosch. I'm a GP and I've been associated with Give a Kidney for the last 15 years, as I was one of the early donors. So, and I go back a long way with Lisa. But I'm not an expert in the sense that I'm not an expert in kidney transplantation, but I have lived experience.
Thank you all. I thought we'd kick off. Please feel free to ask your questions at any time during the session, and we'll come on to those in a few minutes. But I'll begin by asking Lisa to provide just a bit of an update on where we are with living kidney donation and transplantation. Lisa?
Thanks again, Bob. So it's very nice to be with you again after a couple of years, I think, since we've done one of these webinars. And the last time, I think the picture was somewhat bleak. And since then, I'm glad to say that it looks much more positive. And probably the first thing to say is that I think living donors and patients have been extraordinarily patient through this time and have really borne with us, and it's been an incredibly difficult 2 years for everybody. And I think that's the first thing that really needs to be acknowledged, is that you've all been absolutely fantastic in sticking with all of us through this and trying to make it all work. On a really positive note, I think, is that I think we are beginning to see our way out of the pandemic, and I'm sure you're all feeling that. And although we have Omicron with us and infection rates are high, actually the impact of that we've still felt that impact, but living donation and transplantation have still really maintained their activity, and living donation is recovering really very well now. We're managing to keep those quarterly matching runs of the kidney sharing scheme, which is so important to our patients, but also important to people like yourself if you're considering living donation, because actually, those are the schemes that you're entered into and included in, and they make such a difference to patients. So keeping those going is our main ambition around living donation through the next year, and all of those, of course, direct transplants within transplant centres as well. So everybody is working really, really hard to make every transplant happen. And I'll just come on to why that's quite difficult still at the moment. In terms of vaccination, well, obviously the vaccination programme in general has been a huge success. For our patients, we're still, I think, trying to understand whether, well, we know that unfortunately, the 2 doses of vaccine doesn't have quite the same impact on our patients as it does on everybody else, because they are receiving medication to suppress their immune systems. And so that's something that we're really looking into in a lot of detail, and we're waiting for data to come out around 3rd and 4th doses of vaccines for our patients. But the good thing is those vaccine doses are available to them, and they are having them and taking them up. And that's really, really important, because although we don't know the level of protection, we do know that it's most likely that if those doses are taken up, that they will be best protected, as is everybody else. But importantly, alongside that, there are also a lot of treatments being developed for COVID, which is really promising, because if you think where we were right at the beginning of the pandemic, where we knew very little, we actually didn't have any clue at all how to treat this. And increasingly, we're having many more, I mean, all the time, there are antiviral medications and different things becoming available that give us choices about how to treat people if they do become infected. So the really important thing is all about stopping people getting seriously ill, and that's our focus there. And I think there's been really huge and positive developments, a testament to everybody involved. So those are all the positives. All centres open for business. Really, we're doing very well, and I think it's a huge success story that we've had so much donation and transplantation activity over the last 2 years. I think that's a testament absolutely to everybody. So I suppose on a slightly realistic, and if this might sound slightly negative, and those of you who know me well, I'm not prone to being negative, but the current Omicron wave, I think, has had quite a significant impact on the workforce. I think the thing, when you have a high level of infection in the community, that affects everybody. And what that has meant is that people have had to isolate and be off work, and that's created quite a lot of pressure within the system. And I'm sure Adnan and Frank will be able to tell you firsthand what that feels like. But that has made it quite challenging to keep our services going, and our services for patients in particular. And living donation, of course, is classed as sort of planned activity. So that sits alongside competing priorities like cancer, cardiac surgery, and so on. So there have been delays. We're aware of this. We've worked very hard as a community to keep living donor transplantation right up there as a top priority. And we have been listened to on this. And actually, we've made some really good progress about keeping it right up in the forefront of activity. So everyone is working really hard, clinical colleagues, donors and recipients hanging in there, and everybody's working really hard to make every transplant happen. And it's a challenging environment still, but I think we're getting through it. And I don't think I'm being over optimistic, but I really think that by the end of this next year, we'll be looking at a very more positive picture. I think we do also have to be realistic that we are going to have more people on our waiting list at the end of this period. Currently, we have just around 5,000 kidney patients waiting for a transplant, and that is sort of higher than it was pre-pandemic, and that's an inevitable thing. But I think in terms of our deceased donor transplant activity, that's virtually back on track. In terms of this year, with our living donor transplant activity, I'm predicting it'll be about 3/4 of what it usually is. So it'll be around about 750 transplants rather than 1,000. But for next year, we're hoping that if every transplant centre did just one more transplant than they were doing pre-pandemic, we would have an increase. So I'm working towards that, and I hope colleagues will work towards that with me. And I'm sure those on this call will want to comment on that. But I think for the moment, that's probably all I want to say. But of course, happy to take questions throughout this webinar. Thank you, Bob.
Thanks, Lisa. Very, very helpful. I guess it's the case of the glass being half full, isn't it? The empty part is the bit that we're not able to achieve at the moment, given the circumstances. But the fact that we've got a glass that's half full is a testament to the amount of work that has gone in by everybody involved. Because I know from the start of the pandemic that basically nothing was happening in terms of actually getting the transplants done, but a heck of a lot of work to plan how it could be made possible even during a pandemic. And that's allowed certainly a fair bit of activity to carry on nevertheless. So certainly at Give a Kidney, we recognize the hard work that everybody at the NHS has put into to try and keep things going in very difficult circumstances. Of course, that does impact on those people that are looking to donate, and maybe there's questions about that as well. So I'm going to hand over to Jan Shorrock, who's going to moderate the remainder of the session. So over to you, Jan.
Thank you, Bob, and welcome again to everybody. It's lovely to be here on a Saturday morning. So I thought, so what we ought to say just before we begin for the people who are asking questions is that our experts here today can give very general advice about living donation and particular issues around living donation. What they're not able to offer is particular medical advice to you in particular. But if you have a particular question, they will be able to tell you whether they can answer it, and if not, refer you back to your unit. Obviously, there are some questions that they would need a kind of a much clearer medical background to be able to answer. But I thought one of the questions we hear quite a lot at Give a Kidney and has come up already in a pre-question that somebody submitted in advance is around the impact of the opt-out legislation, which of course came in 2020 during the early stages of the pandemic, and a question around do we think that the opt-out legislation for deceased donation will impact on the need for living donors in the future? Is the need still as great, and why? So I'm not sure who wants to take that. Lisa, perhaps initially, or Frank? Happy
to. So first of all, I think it's fantastic that the new legislation came through. For several reasons, I think it's too early to tell whether we can measure any effect, to be honest. I think, first of all, the shifting culture that donation is the norm rather than you have to opt in and actively say that you wish to be a donor is, I think, a good thing that people are now growing up in. And hopefully in the next years, we will see the effect of that. So that's long term. I think for the immediate term, the NHSBT has made some projections, of course, that kidney transplantation and all kinds of transplants will increase up to 25%, but it's very difficult to make an absolute prediction. Then, of course, we are still in the pandemic, even though we may see the end of the pandemic coming. Hopefully, I think that has severely impacted on donation and transplantation activity in general. So I don't think we can say anything useful about it. I do feel very strongly that whatever happens with the opt-out system, whatever happens to organ donation in general, living donation will always be at the forefront for kidney transplantation and should be the preferred option still. For several reasons, and I think people know that, and I don't want to sound like a broken record, but preemptive transplantation, which is doing transplantation without the need for having any form of dialysis, should be the norm, should be the default option. And this is where living donation, of course, can really come in with early referrals and early live donor workup and early mindset towards transplantation is one of the key factors. And still all the other options and all the other benefits of living donor kidney transplantation will definitely stay, such as if you have an incompatible donor for not matching blood groups, or even if you have antibodies against a donor, there's still the sharing scheme, which we are very proud of as a UK transplant community, that brings additional options to still, by exchanging kidneys across the UK, still give extra transplant options. So if you don't have a living donor, obviously the deceased donor waiting list is still a very good option and still much better than going on to dialysis. But that's why I think living donation should always stay and always keep that prominent position. And I will stop here because I'm sure others have other things to say as well.
everything Frank has said, I would absolutely concur with. I think the thing that I would say is that the opt-out legislation appeals to the general population. And of course, you could say it has a competing interest with appealing to our non-directed donor population here in the UK. I think what I would say, the really important thing to remember is our non-directed donors are absolutely invaluable. They're our game changers in the kidney sharing scheme that Frank's talked about. And so I think we just need to be really clear we're appealing to a very, very different market here, that we do not use our deceased donors in our living kidney sharing scheme, partly because we have the benefit of wonderfully generous people who donate when they're alive. And we want to keep it that way. So I would say, yes, I think there is a risk that people will assume that we will have enough kidneys to go around. We won't have enough kidneys to go around. So please don't consider that as a reason not to step forward if you're considering doing so, because our non-directed donors are absolutely invaluable and have created those transplant opportunities, amongst others, in the kidney sharing scheme, in those initiating those chains.
I mean, I'll quickly just jump in and just echo everything that Frank and Lisa have said. And I mean, certainly the you know, when you look at all the opt-out countries that have that kind of legislation, you know, the live donor rates are possibly much the same, if not, you know, a little bit lower, and that's something that's something we're going to be looking at in the UK. And that may just be a kind of a philosophy that people think, oh, well, we've got opt-out, so we don't need any living donors. We do need living donors. And just to kind of echo what Frank said about living donation being considered the gold standard, I mean, I obviously look after people with kidney failure who may be on dialysis, and when it comes to transplantation, which is the best option for people if they are fit enough for the surgery, but sometimes for some individuals, their kind of risk versus benefit margins are they're very much on the borderline when it comes to perhaps getting the kidney from the waiting list. But the advantages of getting a live donor means that for some of them, they may not be suitable for a kidney from the waiting list, but they are suitable to get a live donor kidney. So it's always going to be a valuable option. But of course, for anyone, a transplant is better than being on dialysis, but a live donor option is always the best option.
Thank you all for that. I just thought it might be helpful, just because we don't know all the people on the call and we don't know their level of awareness of living donation, just to maybe cover off some of the terminology, particularly the difference between non-directed, sometimes also called unspecified or anonymous, or all sorts of other things, altruistic, and directed donation. So would somebody just firstly be able to explain that, and then also a little bit more about the kidney sharing scheme? But if we start with the terms around the different types of living donation or living donor first, please.
Shall I start with that? Because we've got these anomalies partly because we have a legal system that calls things certain things in the UK, and we also have colleagues who have come up with definitions that they feel are more appropriate. I think that's fair to say, Frank, isn't it, in terms of how we describe relationships? So it is complicated. I think, to put it in the simplest terms, if you're living in the UK, a directed donation is one from somebody where there is a direct relationship between the donor and recipient, either by blood, so genetic, or emotional, so a spouse, partner, friend. So loved one or friend, that's your directed donation, and that tends to happen in the same transplant centre and the couple are known to one another and to the team who are looking after them. Non-directed donation is in the letter of the law called non-directed altruistic donation, and we've moved away from calling them altruistic donors largely, partly because of the influence of Give a Kidney, actually, because Give a Kidney members describe themselves as non-directed donors because you're giving to somebody who's previously is unknown to you or you've never met, and that is described in the letter of the law as a non-directed altruistic donation. It's non-directed because it's directed towards somebody who is unknown to you. And also that term applies within the kidney sharing scheme and when kidney exchanges happen between two pairs. So somebody is actually giving to somebody in an indirect way. So it gets a little bit muddy, but if you talk about non-directed donors, they're the people who just step forward to volunteer to donate to someone in need of a transplant. Then we also talk about paired pool donation in the UK, and that's where two couples may be involved in an exchange with one another, each donor donating to the opposite recipient to facilitate a transplant for everybody. And a pooled donation is when 3 or more pairs are involved. These are the descriptions in the UK. And I think the final thing to say is you will also hear, and Frank certainly uses this terminology a lot, and I do intermittently when I'm not speaking about UK speak, is unspecified donors. That's equivalent really to the non-directed donors that we talk about in the UK. This is it's fair to say, European definition that was derived from a group working with called LPAT, working within the European Society of Transplantation. Frank and I are part of that group. And some time ago, a group of colleagues felt that the unspecified donor was a better way of describing, but it's not the legal term we use here. So we've sort of stuck to non-directed because that works for the UK population here. The final category to just talk about is directed altruistic donors, just to make it really confusing, or your dads. And they are people who step forward in response to somebody that they become aware of who needs a transplant, perhaps a distant relative who they haven't seen for a while. So there isn't an established relationship there, but there is a connection from the past, or even responds to a social media or a media campaign. And these are called directed altruistic donors because they have knowledge of their intended recipient. And so there's a slightly different terminology applied there. But I hope that that's clarified a little, and if not, please put questions in the Q&A and we will elaborate.
Thank you, Lisa. And you talked briefly about the kidney sharing scheme then, and I just wondered if it might be helpful. Give a Kidney's remit is primarily around non-directed donation for the people who step forward just to donate to somebody in need on the waiting list. And just, I thought it might be helpful, there's a question around this, is why these particular donors make such a difference to the sharing scheme, how they're used in the sharing scheme to trigger the chains of transplants. Lisa again, maybe, and then we'll.
I'm happy to answer, yes, and then I will be quiet for a while. So the reason that non-directed donors make such a difference is because if they donate into into a pool of patients who are in there with a willing donor, but a donor who initially we set this scheme up for not compatible. And when we say not compatible, that means by either the blood group, they're not a suitable blood group to donate for the donor to donate to the recipient, or a suitable, what we call HLA type or tissue type. That's probably the simplest way to describe it. So for those incompatible pairs, if you add in the non-directed donor, and then we press a button on a computer with all the pairs in the pool and the non-directed donors, we can identify recipients within that pool to whom the non-directed donor can donate. And the joy of that is that that person donates to a recipient in the pool. Their paired donor can then donate to another recipient, and their donor could then donate to somebody on the transplant list. And the real joy of this is that you might have 1 or 2 pairs in the middle as the system is set up at the moment. But from a single donation, you have made possible up to 3 transplants, including somebody on the deceased donor list who doesn't have a living donor of their own. So you can see it's a bit of a win-win, really. And just an important clarification, I think, which is important for people to know, is this: people who are really high priority, the most difficult people to transplant on the waiting list, are not disadvantaged by this system, because before we put any non-directed donor into our kidney sharing scheme each quarter, so this runs 4 times a year, we check that there isn't what we call a high priority, a really difficult to match patient for whom this kidney would be their golden ticket. And if that's the case, then that kidney will be offered to that individual first. So really, the system as it runs benefits everybody waiting for a kidney transplant. So the real game changers are the people who come forward to donate, because they don't have any recipient attached to them. So they're a bit of a free radical, if you like, and we have much more freedom for them to unlock a chain of transplants. I hope that's explained that for you, Jan.
Thank you, Lisa. Very, very helpful. So there's a number of questions coming in from people that have been submitted in advance as well, from people who are in the process of the workup. So I thought we might just deal with some of the questions that are coming from those people. So there's a question on the Q&A, so thank you for submitting this, around geography. So this person lives in Berkshire. Their intended recipient is in Leeds, so a directed donor. And the nearest transplant unit is in Oxford. But the question was, is there an added benefit or advantage to having both the donor and recipient in the same hospital for the transplant, for the donation and transplant, as opposed to two separate donations? So that might be one for Adnan or Frank.
Sure, you want to go, Adnan?
I'm sure we'll probably say the same thing, but I mean, certainly from my perspective, I mean, yes, I mean, obviously, in an ideal scenario, if they are done at the same hospital, it does work. But I mean, we have to be kind of quite practical and work in the real world. And it's not unusual often for people to donate in one centre and the kidney to travel to another centre if that is what works best for all people involved. So I mean, I think we're quite realistic and we're quite practical. If it is possible to do it at the same centre, yes, that just logistically does work better. But I guess the logistics, it's better for us as the professionals, but obviously we need to make sure that it works well for the donors and it works well for the recipients. So we just look at it as the big picture and just try to work out what works best for everyone involved.
I can perhaps add a few things from a surgical perspective. It's very much also up to the preference of the donor, I would say. Some people that live far away are more happy to stay close to home, so that in normal times, at least, they could have visitors come over and at least family supporting them or social network supporting them to go to the hospital, come out of the hospital is a bit easier. Also, to do the workup in the center where you have your surgery, I think is quite important. But of course, this can be transferred. I'm from the Netherlands originally, and for our sharing scheme in the Netherlands, we used to have the donor travel rather than the kidney to various other units. And you basically just had to have one extra visit to see that all the workup was was fine, also according to the operating surgeon and live donor team in the donor center where the surgery was taking place. We do know that, and I think that's important for the sharing scheme already, as Adnan said, kidneys are already being transferred from hospital A to hospital B, and we just actually published also that the time that the travel takes, the kidney obviously is on ice, doesn't get oxygen or blood. That's not detrimental for those kidneys traveling, and even up to 10, 12 hours, this is shown not to be a problem for the outcomes. And I think that's very important. So I think in the end, it's up to preference of the donor, I would say, that could largely drive this. And everything should be, you can discuss everything with your donor and your recipient centers, because everyone in this field is quite flexible, is my experience.
Thank you both. So there's a question here about somebody who, this was submitted in advance from Emma, who has had her workup done to become a living donor and has been in the matching runs since October, but not yet been matched. So she's asking about the testing process and which, if any, tests she may have to repeat or how long those tests kind of are valid for before she might have to go through some of that process again. I think, is that Adnan or Frank? Adnan, perhaps?
Either or.
Both, either or.
Yeah, it very much depends on the individual tests, but I mean certainly with regards to blood tests are usually kind of reasonably straightforward to do, and we some people can be in the process for say a year or two, and we would want to have kind of annual blood tests and maybe an up-to-date ultrasound scan for the kidneys. If we're talking about kind of a very long period of time, so for example 2 years, then some of the kind of CT scans and things would need to be repeated. But often, things like blood tests, urine tests, they're quite simple and straightforward to do, so they can be repeated, as required. But I think it very much just depends on individual circumstances and which tests we think are important to have up to date.
Thank you, Adnan. So there's a couple of questions coming in. I'm going to try and get through some of the ones that are coming in on live. So there's a question about the proportion of kidney recipients subsequently needing another transplant. So it's about longevity. So I think you said if living donor kidney transplants generally work better and last longer than those from deceased donors. How is there a kind of figure for that? How much is that improved in terms of numbers of years or cost savings on dialysis? I think maybe Adnan, you've answered this question for us very recently, I think.
Yeah, I mean, we always kind of say that obviously receiving a live donor transplant, works out with better longevity. Apart from the survival benefits for the individual, the longevity of the kidney is longer. I think probably the current statistics, correct me if I'm wrong, Lisa and Frank, but I think 10 years after a live donor transplant, I think over 70% of those kidneys are still working, which is higher for kidneys from the waiting list. I think another way to sometimes think about it, which is often reported, is that we expect half of live donor kidneys to still be working after about 18 or 19 years. So, I mean, without a doubt, you do get added years from a live donor transplant compared to a kidney from the waiting list. And with regards to the health economics, I mean, every year that a patient with kidney failure is not on dialysis is saving the NHS a significant amount of money, apart from the morbidity, the complications, and the mortality that our kidney failure patients who are on dialysis have to live with.
Thank you, Adnan. Did you want to add anything, Frank?
Well, perhaps the economic advantages, these are, of course, on top of the quality of life for the individual, and taking into account that this individual can contribute to society in various ways. Again, for example, people are more likely to work after a transplant versus being on dialysis. And if you have that for a longer period of time, obviously that translates into benefits for the NHS as well. So there's some rough calculations. It's always difficult, but in 10 years' time, any live donor transplant could save the NHS up to £650,000. And of course, this is difficult to calculate, and this may not be an exact figure, but it's a lot of advantages for the NHS on top of the individual advantages of the patient, whilst the donor should still be in very good health and good quality of life as well.
Thank you, Frank. So there's a couple of questions, one that came in before and one that's on the chat now around GFR or EGFR. And the question that came in advance was around what happens to somebody's EGFR after donation and after receiving a kidney, and do you expect that to stabilize? So maybe it's helpful just to explain what EGFR and GFR are first, and then explain what happens to those after donation. And there's a question in the chat about the GFR just being borderline for donation, and a concern about whether it would cause low kidney function beyond donation. I don't know if you're able to answer that in general terms. Obviously not.
I mean, I can start with that. So when we're talking about, as kidney specialists, when we're talking about kidney function, we're usually talking about something called creatinine, which is one of the toxins that builds up in the bloodstream if your kidney's not working very well. I mean, there's lots of toxins that do build up, but creatinine is the one that we can measure. But your creatinine can be influenced by age, it can be influenced by sex, it can be influenced by your body size. We used to previously also think about ethnicity as well, but that's now been removed. So a creatinine of, say, 200 in one individual means a different level of kidney function compared to a creatinine of 200 in a different individual. So what we do is we now correct for those things, and that gives us an estimate of their glomerular filtration rate, or your GFR. So that's where the eGFR comes from. But you can have two blood tests done probably a minute apart, and your creatinines can vary a little bit, and therefore your estimated GFR can vary a little bit. So when it comes, which is fine for day-to-day practice when, say, Frank and I are looking after patients in clinics and you're getting bloods done in clinic, but for the purposes of kidney donation, an estimate of your GFR or your level of kidney function isn't good enough. So we want to have a measured GFR, and that's some of the tests that our donors have to go forward with. And with regards to what happens to kidney function after you donate, I guess the easiest way to think about it is if you start off with 100% at the very beginning, and let's assume both your kidneys work 50% each, contributing to that 100. That's not always the case. There's usually always one slightly stronger, one slightly lazy. So you often see 51% and 49%, or 52 and 48. But let's just say you start off at 100. Both kidneys work 50-50. One kidney is removed, so you instantly drop down to 50. Most estimates are that within about 2 weeks, the remaining kidney kind of beefs up in size and beefs up in the amount of work it does. And it's probably already risen up to, say, something like 70 or 75% of where you were before. And in the long term, it goes up a little bit higher, and you probably end up with something around maybe 80 or 85% of where you were at the very beginning. So those are the changes that we see after live donation. And obviously, with regards to the person who's been on dialysis and whose kidney function is effectively 0 or less than 10%, their kidney function will improve, and their GFR or estimated GFR will stabilize out. But there's lots of things which influence what level of creatinine and what level of GFR an individual who gets that transplant ends up with. Again, depends on the age, sex, body size, etc., etc.
I just add how fascinating this is, that basically you take one kidney out, you would expect, say your creatinine is 80 when you donate, you would expect the creatinine to double because you only have one kidney left. But this never happens. I mean, immediately, as Adnan said, immediately the other kidney feels that it's alone and starts to work in a bit of an overdrive situation and beefs up, as he said so nicely. So I'm every time still fascinated by this, and we always ask students to predict what the creatinine will be the next day, and they always get it wrong.
Could I just add a note of caution, because I think it's something that scares donors after they've donated, and this is something we and Paul, who as a GP will have sympathy with this, but eGFR is something that now can be automatically generated from your blood results in every GP practice. And what happened it's something, as Adnan has said, that we use to look at function in people with two functioning kidneys, or two kidneys, and looking at what's happening to their kidneys. In somebody with one kidney, eGFR can be very misleading, and it can suggest that you have got kidney failure when you haven't. So just as a word of caution, if for any reason somebody flags an eGFR, if you have donated, that appears to be low, that is because you have one kidney and it's not the measurement that we use. And I just want to say that because it's such a common anxiety for people, actually, if it's not properly explained. And so we do have information on the NHS Blood and Transplant website about this, because it's something that has come up so often, we felt we should do that. But that was just really to reassure people, you haven't got kidney failure. It's a measurement that's applied to two kidneys, not one. And so in that context, we ignore it unless it's being discussed in the context of a discussion about your kidney function. Paul, I don't know whether you want to add anything to that with your GP hat on.
Well, I can talk from personal experience that my eGFR 15 years on, I've had it tested for no very good reason recently, but remains excellent. It's over 80, and every day I'm looking at the results of patients of my own age. And I have to say that my figures score pretty well by comparison with most people in their mid-60s, which is how old I am now.
Thank you, Paul. I want to bring you in again in a little while, Paul, but there's just a couple more questions that kind of seem to fit in this section, really, about kind of, yeah, the kind of medical part of and surgical part of transplantation. So there's a question about, it's probably a surgical question, well, probably, again, Adnan and Frank, sorry, about, is there a preference for left kidney or right kidney? And this person, Vivian, thank you for the question, has read some research about perhaps the left kidney resulting in fatigue in the donor, potentially. Is there any evidence for that you're aware of?
So let's go back to the reason as to why the left or the right kidney are chosen. First of all, the key principle of live donation is that the donor keeps the best kidney if there is a difference, because the donor risks should be as minimal as possible. So there's a lot of factors actually that can influence the choice for the left versus the right. The two kidneys are not exactly the same, because the way basically where they're situated in the body, the left kidney has a longer draining blood pipe, which is called the vein, the renal vein. And on the right side, the kidney is closer to the main draining blood pipe, the inferior vena cava, for those of you who are interested. But that renal vein, the draining blood pipe of the kidney itself, is quite short. There are quite a few people who are reluctant to use the right kidney, and some people have really short veins or a couple of those draining blood pipes, which makes it a bit tricky for them, but also for the recipient surgery. So, overall, you would feel that in transplantation, most of the surgeons would prefer the left kidney, but there are definitely reasons as to why the right kidney could be chosen. For example, if the right kidney has one artery, so the blood pipe that brings the blood and the oxygen into the kidney, and one vein, the draining blood pipe, that is sort of a straightforward kidney. Versus if the left kidney has, say, 3 arteries and 2 veins and 2 ureters, so the tube that transports the urine that the kidney makes to the bladder, then obviously that would be much more tricky, both for the donor surgery as well as for the recipient operation. So then it would make more sense to have the right kidney removed in that scenario. So there's anatomy that can drive it. Also, if one kidney is larger than the other one and contribute way more, say, Adnan was saying, normally it's 51 versus 49%, but sometimes it can be 60% for one side to 40% for the other side. And obviously, the donor should keep the kidney who contributes most to the kidney function. So the kidney with the 40% would then be the one for donation, unless there's compelling reasons to divert from that plan. And then there's some other things. There could be cysts in one kidney and none in the other one. And obviously the one with the cysts could then be considered the one to be donated. So there's quite a few complexities, but the key principle is the best kidney stays with the donor. I'm personally not aware of increased fatigue from the left kidney versus the right kidney. I don't think there's evidence for this, but please correct me, colleagues, if you have seen anything on that. So I don't know where this comes from. Certainly not witnessed that myself. And as I said, most donations come from left kidneys.
Absolutely, I'll just second everything that Frank said. And again, I'm also not aware of any kind of fatigue related to left versus right kidney donation.
Thank you. It might be interesting to share that paper, Vivian, if you feel able to after the session, so we can have a look. Thank you. So there's a question about the surgical question, but Paul also might want to comment on this, which is about scars and why some donors have scars in different places to other donors and where the most likely scars are likely to be. So I guess that's one for Frank, and Paul might want to comment from personal experience on this too.
Oh, you want to start?
I have no issues about my feet. It causes me no issues whatsoever. But I'm much impressed by my surgeon guys. So
I think you're breaking up, Paul. I think.
sorry,
Is that the same for everybody
I have
else?
no issues with my scar. It was very straightforward, simple, and has never caused me any problems whatsoever.
Okay, thank you. I don't know if everybody could hear that clearly, but I think he's saying he didn't have any issues with his scars and they've not caused him any problems whatsoever. Frank, do you want to? You're also in very bright sunlight, Paul. So it's quite hard to see you. That's better. Thank you. Frank, do you want to talk about scars and where they might be cited and why?
I mean, it is the key principle is that basically there are several techniques to remove a kidney in a live donor. Most commonly, I would say 98 to 99% of all the live donor nephrectomies, as this operation is called, are done with the keyhole technique. So laparoscopic donor nephrectomy is the nice term for Scrabble tonight. These techniques have variations, and every surgeon does it more or less in the same way, but the scars to extract the kidney in the end, because even if you do the whole operation with a few small holes with small instruments going through a little tube in the abdomen, those little scars can vary based on where your kidney is and how big it is and how difficult it will be. But the extraction side, in the end, you have to remove a nice juicy kidney. You can't remove it through a centimeter hole. So that in the end will be normally a sort of a small C-section. And there's variations in there where people remove them from. So most commonly, this is where C-sections are done for baby deliveries. So right above the pubic bone, and that should normally be 5, 6, 7, 8 centimeters, depending on the size of the kidney and the size of the donor. But can also be in the midline under the belly button towards the pubic bone. And for example, some surgeons put them where an appendix is removed, so more to the sides of the belly button. So that varies. And there's nothing better or wrong, it's just a different approach. And also it depends whether the surgeon puts her or his hand in the belly during the donor nephrectomy, because this is called a hand-assisted keyhole technique, and there's variations to that as well. So that also can make a difference in how many small scars you have and where they are exactly located. But in the end, it shouldn't make any difference.
Thank you, Frank. I want to bring Paul in a little bit here. There was a question in advance around what recovery actually is like, or how it was, what's it most likely to be, how long the hospital stay is, how long before people can be back at work, etc. I don't know if Paul might like to talk, if we'll check your sound, Paul, but whether you might want to talk about your experience of donating and what your recovery was like first, and perhaps others can interject as to whether that's a usual kind of recovery that you would be expecting.
I mean, I think the first thing to say is that it does vary quite a lot, and that it would be unfair to be too specific about how long it takes. From a personal point of view, I was in hospital just for 2 days, in fact, and out, and then I was off work for 2 weeks, and then I was back at a desk job and pretty much functioning as normal. I think that's quicker than most, but I'm self-employed, so there was a lot of pressure on me from my colleagues to get back very quickly. I think most people, my wife, who's also been a donor, was off work for about 5 or 6 weeks, and her job involved being on her feet rather more than mine did. So those are our personal experiences. I know other people have taken longer. Interestingly, in the States, where the sort of social security network that supports people is so much more fragile, I think the time that people are allowed off for almost any illness, including sort of donation, is much shorter on the whole. But I think that on average, talking to other people, my experience is that people are pretty much functioning as normal within 6 to 8 weeks.
Yeah, if I can come in there, thank you, Paul. That's very helpful, and I think it varies indeed, as you say, and it would be unfair to say to everyone that after a week you can do everything again. We do also encourage people to take time off. I personally do, because quite often the time leading towards the donation, it's been a roller coaster, especially if this is happening in a family, if it's a specified or direct donation. There's so many things going on, and quite often people are in an emotional roller coaster, and it would be good to actually spend time on a good recovery. And most of the people that have jobs and are working and are not self-employed, quite often the employers are very supportive, but of course not everyone. So this can lead to some stress and pressure. And that we always try to support, and Lisa may say a few words about how NHSBT can helps with basically compensating for that. But in general, I think I would always recommend people to take 6 to 8 weeks off if they can. And we normally see the donor back after 2 weeks after their donation, or 3 weeks, and it depends a bit on the logistics. And I think I do encourage everyone to get out of the hospital as soon as they can. So this is a new, when I got trained, we used to always keep people in the hospital for as long as possible, and everything had to be perfect before you basically could send someone off. But now we know it's much better to not be in the hospital, not get medicalized by all kinds of doctors wanting to add other drugs and treat you as a patient rather than as a donor. I think my mindset, I've learned a lot from all my donors. The quicker they get home, the better and the happier they normally are. And of course, they still need care. And it's really good to consider in advance who's going to look after you as a donor, but you shouldn't be terribly sick, obviously, after a laparoscopic donor nephrectomy. Otherwise, we've done something wrong. So there is a support system needed. And my advice is take the time for physical and emotional recovery.
Thank you, Frank. Lisa, could I just add into that, because it kind of ties in with another question that's coming in about on the chat, thank you, around this person is just starting to consider or starting the workup process to become a non-directed donor, but I guess it applies to directed donors too. So any advice about approaching employers, or what your experience has been of employer support, and also tying into that, Lisa, perhaps around expenses and how time off work, what kind of expenses can be covered during this process, please. Thank you.
Okay, I'll try and Jan, keep me on the straight and narrow if I don't cover all the points that you think you'd like me to. So to start with, I completely concur. I mean, I'm obviously delighted to hear that Paul bounced back quite so quickly, but as he's quite realistic, I've known Paul of old, and that doesn't surprise me, if you know what I mean. And I think that managing expectations is a really important thing, particularly if you're in work, because you don't honestly know how you're going to feel unless you've ever been through a major operation. And even though you have a small scar on the outside, I always say to people, a lot's happened on the inside, and Frank will hopefully concur with that. So it's really important to be realistic that we call this major surgery for a reason, and that's not to frighten people, it's for people to be realistic, because we do tend to have many of us are over optimistic about what we can do when we're not so well. So great, I absolutely concur, minimal time in hospital, and that's what we all aim for, and then give yourself this time afterwards, and that will vary, as Paul and Frank have pointed out. In terms of employers, I normally say if you're doing a desk type job, you should say 6 weeks. I may be off 6 weeks, but it may be that you could go back for a phased return between 4 to 6 weeks. And what I found interesting in my conversations with donors over the last little while through COVID is that, of course, many more people are working from home now. And the tendency is, as Bob has actually said, this is not working from home, this is living at work. And so the boundaries are not clear at all. So just be kind to yourself, I would say, and say, actually, because you've had a general anaesthetic, you've had an emotional upheaval, you've had a physical experience, and this all plays into your recovery time. So and everybody will manage that differently. So manage expectations, particularly if you're in work. And I would say if you're doing a very physical job, the 8 weeks is probably realistic, but you might want to say, it may take me up to 12 weeks to be back to absolutely where I was before. You know, just to be completely realistic, and it'll probably be less. And the way I work on that is that it's always a bonus to say, well, I'm back sooner than you thought I'd be. So that's my philosophy. In terms of support, so Frank mentioned NHSBT, which is the organisation I work for, NHS Blood and Transplant. Actually, the reimbursement policy, we did work and collaborate with commissioners to make a reimbursement policy that worked across the UK. So wherever you live in the UK, you should have the same access to the same privileges. And the principle behind the policy is that anybody donating is not financially disadvantaged. So it should be cost neutral to you in terms of money. And so if you obviously have to make the claim, but you can claim a variety of things, including travel expenses, loss of earnings. It can be quite tricky if you're self-employed to keep records sort of easily duplicate, easy to show the evidence for that. But you can do it on things like tax returns and so on. And the coordinators, the living donor coordinators, will help you to submit those applications. Now, I'm not going to say that it is a completely glitch-free process, but the principles are there. There is a policy there, and we work very closely with commissioners to support these claims if to ensure people are reimbursed appropriately. And we do pick up on any glitches if we can, and support them to be managed as well as possible. So there is a policy there. Do not be embarrassed to use it. It's there for a reason, and it's there because we don't want our donors to be out of pocket as a result of doing something that's incredibly generous. I hope, Jan, that's covered most of the points, but come back to me if not.
I'm on mute. Thank you, Lisa. Yes, I think so. But if anybody has more questions on that, do put them in the Q&A or chat, and we'll come back to them. There's a number of kind of quite quick fire questions, I suppose, that probably have quite short answers that I'm just going to try to cover off quite quickly. So one on the Q&A, thank you, around is there anything in terms of general health and fitness that a donor can prepare for pre-donation? Any specific things they ought to be doing in terms of diet, exercise, etc., to help their tolerance of the donation?
Nothing specific, but I think overall, make sure you have a nice regular rhythm, do exercise, sleep well, have a healthy diet, but no specific tips or tricks there. And of course, it's just general fitness that you can exercise.
Thank you. And after donation, anything that donors need to take note of or change in terms of their lifestyle? Anybody?
I'll jump in there. I think pretty much the exact same thing that Frank has just said. So it's just encouragement of healthy living, good diet, good exercise. And I think that's the important thing, is just like kind of healthy lifestyle. And the same advice for before your donation exists after donation as well. Obviously, we wouldn't. Sorry, I was just about to say, I wouldn't recommend you kind of start doing vigorous exercise in the first few weeks. So that's the kind of caveat. But in the long term, yes, it's just maintenance of a kind of a healthy lifestyle.
Can I just add, perhaps to avoid the use of ibuprofen and that kind of drugs, the non-steroidal anti-inflammatory drugs, because they can be detrimental for kidneys. That's for every kidney patient, but also for living donors for the rest of their lives. So if there's ever any doubt as to whether you can have a certain painkiller or certain antibiotics may have the same sort of effect, it's good to avoid them. So if there's doubt, obviously Paul, GPs will know, not all of them, but Paul will know, so you can all ask Paul. And of course, the live donor team in your transplant unit will be able to advise.
Thank you. Do you want to say something, Paul?
Can I just add weight as an important issue as well? I think that's probably goes without saying as an essential component of fitness. But I guess from your point of view, Frank, it makes your job technically much easier if people aren't overweight. But it certainly and it contributes to a diminution of renal function in people who are very overweight. So that's something to bear in mind both pre and post donation.
Thank you, Paul.
Thank you. And we are sometimes asked actually on that topic around BMI and are there cut-offs on body mass index to be a donor in particular? What are the recommendations for that?
So it's a very difficult one actually, because that varies per transplant unit in terms of philosophy, but also BMI is not the only thing to go by, because some people are very muscular and short, for example, and they may have a very high BMI, but are actually not obese. I've had people that were, this was in the Netherlands to keep it safe, that were declined to be a live donor without even having been seen, because basically on a BMI. So BMI is one of the parameters to check if someone is obese or not, but there's definitely the shape of a person does matter. There's two things to it. First, there is the concern, of course, by some surgeons, whether or not the operation is safe. I personally don't think that should be an issue, because there are several techniques and you can adopt your technique to a complexity of the donor. So obesity is one of them. And for example, employer hand-assisted technique, you can avoid lots of the trouble. But of course, there's the other element, and Adnan might want to jump in there, is if you have if you are very obese and you have one kidney only, the kidney will have to do lots of more work and might actually be hyperfiltrated in the long term. And that, of course, can be associated with problems. And on top of that, obesity is often associated with some other, as we call it, metabolic problems that may actually lead to complications in the long term. But that can be checked, right, Adnan?
Yeah, absolutely. And we've mentioned about how your GFR, your level of kidney function, improves when you've got one kidney after the other one leaves. And I think Frank mentioned earlier that there's hyperfiltration, but there's other things that can contribute to hyperfiltration in a bad way, and obesity is one of them. So again, yes, in the long term, I think it's that healthy living, good diet, exercise, keep your weight down, and be very active.
Could I I'm just listening to this conversation and agree with everything Adnan and Frank are saying. I just wanted to pick up on the variability between centres aspect, because I think that's really confusing for donors and for patients actually. Well, if I go to centre A and they'll say yes, and I go to centre B and they may decline me. So we do have UK professional guidelines which are evidence-based, and in those guidelines there are recommendations about donors with different body mass indexes, just as Frank has described. And of course, the ideal thing is we'd like everybody to be as fit and healthy as their best possible version of them before they go into donation and come out in the same way. And that's our aim. So a lot of this is what we call fine-tuning. But I do just want to say that we also have a principle of working together as a community. And different centres will have legitimate reasons for saying that they would prefer to do certain things in certain ways, as I'm sure Frank and Adnan would agree. So what I would say is that if you have a decision and you discuss it, I would recommend you discuss it with your team there so that they understand what your feelings are. But then you could always ask if you could maybe go to somewhere for a second opinion, because it may be that another centre, for a different reason, because there is a different kind of operation happening there or something like that, that may be available to you. So I'm not suggesting wholesale everybody moves around the country because they're dissatisfied, but what I am saying is that there are, if you think, well, I wonder if I could get a second opinion, that is open to you actually, unless there's a barn door obvious reason. Clearly if you've got one kidney, you're not a suitable donor. But there are other situations, and there are things like body mass index, like I can't think off the top of my head of something else, but this is a particular issue that does come up, and I think it can be very reassuring actually the second opinion may say the same thing, but then you sort of have closure on the episode. And I just wanted to sort of pop that in, really.
I think it's very important, and also for you to know that you can ask these things, and we will always be happy to address these things and send you to another unit where we think, you know, there's a similar experience or have a different approach. We do know each other all very well, and there's a very good communication within the community. So absolutely nothing that should stop us from having another opinion.
Actually, Jan, I'm sorry, I'm just going to jump in on one thing, because one particularly, I said I couldn't think of another issue, but of course, a very obvious issue is the one about donor age. And, you know, any adult, 18 in everywhere except Scotland, which is 16. So anyone over 16 or 18 could be a living donor. But actually, there are some centres that feel, for various reasons, more comfortable for people to be over the age of 25 or the age of 30. That may not sit very comfortably if you're under those ages. So if you did want to go and see somebody else and at least talk to them about what your options are, that would be open to you. And that's another sort of example, which is slightly different from the physical things. But again, don't feel you can't ask, because it's important that you have the answer to the question that you have.
Thank you. And another one which may be fairly swift, but are there particular conditions that preclude people from being considered as a donor? So there's one particular question about somebody who's had bariatric gastric sleeve surgery. Would they be able to be considered as a donor? But other, we get often, I think quite often, if you've had a previous cancer diagnosis, that comes up quite a lot. Does that preclude you from being considered as a donor?
So I'll pick up on the first bit, if you don't mind. So bariatric surgery in general should not be a no-go. Obviously, there could be reasons that a person is not a suitable donor, but by itself, having had bariatric surgery, it may actually be much better. So that's fine. I think there's differences for cancers, and Adnan might, because it's one of his key interests and expertises. But of course, cancer is not just one disease. So there are particular cancers where it's an absolute no forever. But there are some types of cancer that, if they have been a long time ago, and where of a particular sort of mild type, and have not been, you know, leading to health problems in general, and cannot be transmitted so easily, they could be considered. But Adnan, you may have a better way of explaining it.
No, I mean, you've explained this, but I think you know, not all cancers are the same, and they all come with different risks with regards to the risk of recurring, the risks of spreading, etc., etc. So I think this is very much an area where, you know, during the workup it has to be looked at on a kind of a personalized basis. The overarching priority, as you know, has been mentioned already in this webinar, is the long-term well-being for the donor, and that's, you know, that's the primary driver for whether someone can or cannot donate. Obviously, you know, there are implications for the person receiving the kidney as well, but the overarching priority will be that individual and what's their risk of that cancer. But then there's lots of, certainly from a medical side, there's lots of things which could be contraindications, but again, there's no black and white answer to give, and this is where you really do need to speak to your team. So I mean, just as one example, having high blood pressure by itself is not a contraindication to donating. However, it depends on the nature of your high blood pressure. So for example, if you are on 3 or 4 medications, that probably would be an obstacle for you donating. Again, the main reason for that is we're thinking about your long-term well-being as a donor. So it very much depends on what the medical issue is, and then really it's the job of the nephrologist and the whole live donor team, the coordinated surgeon and the nephrologist, to look at you as an individual and to work out whether it's safe for you to donate.
Thanks, thank you, Adnan. And there's a question here about the probability of somebody who has been a living donor requiring a transplant themselves in the future, and what the evidence for that is, and just as an addition to that, what the process would be in that situation if they had been a donor and then for whatever reason suddenly actually needed needed a transplant themselves. Is that Lisa, perhaps?
I can start, but Adnan and Frank may want to chip in. So let's start with the end of the question first, I think is probably an important one. We established some time ago in the UK that if for any reason a living donor of any organ requires a transplant, that they will be prioritized for transplantation on the transplant waiting list. And it's really clear, it's really important that that people understand what that means, because it doesn't mean that puts you above absolutely everybody else, because from my earlier sort of explanation about how that list works, there are a group of people who are the most difficult to transplant at the top of the list, and they are the most difficult to match with anybody in the population. So they will always be the top tier, if you like. But the next tier down, within that tier, you would be prioritized within that tier to receive a transplant should you need one. And that's something that now has been in place, I suppose, Frank, about 5 or 6 years in the UK, and is important for people to know. But that is in the context of this being an extremely rare event. And the reason that it is a rare event, and we're proud of that, is because we are very rigorous in how we assess people for donation. It is not our interest as a group of people who care for patients and other people to put healthy people, make patients out of healthy people. And people come forward as healthy living donors, and that's the way we want them to remain. Having said that, life happens, and things happen serendipitously to our health as we go through life, which have nothing to do with us having one kidney or having a kidney removed to donate it to somebody else. And we can't predicate against those, but it comes back to the previous question, that actually this very thorough examination of the individual who is donating is critical. So not only their past and present medical history, but also, if possible, any immediate family members who may have been affected by a disease that could have been inherited, that again could have an impact. But we can't predict that against the serendipitous. So I think the key thing to remember in your mind is that we will do our absolute best to protect you against what we think could happen. The more life years you have ahead of you, obviously, the more time, in a way, there are things to happen to you. And I suppose if you donate slightly later in life, you have more life experience behind you to know whether or not you've had any issues. But I think the really important thing is to remember is this is a rare event, but we have made contingency because we believe that we need to give back to people who've given into the system. I don't know whether Frank or Adnan want to add to that.
Yeah, it's absolutely fine. And thank you, Lisa. I do think that this element is not always not well known, that people actually get some sort of priority for a kidney transplant themselves. I always call it the sort of ultimate safety net, and I see it really as part of the vigorous workup. And in continuity, actually, is the follow-up, the yearly follow-ups that we do, where we try to tackle problems early if they arise. And at least it's like an MOT of a human rather than a car. So I do think it's important to offer that. And some centers offer that in liaison with the GPs in their area. So it doesn't mean that there is always a need to come to the transplant unit. That's the way it's organized, as long as it's there. I do think, for example, the risk of becoming a kidney patient yourself as a previous donor is still lower than the community. And this is because it's such a screened and such a basically well worked up cohort of people. That should remain low, but we do know it's, of course, there is a relative risk, which is a very difficult term, but there is a slightly increased risk for kidney disease in sort of decades time, mostly. I've seen a handful of people, quite often it was unrelated to kidney problems. Quite often it was they had 10, 15, 20 years later, they had an unrelated kidney cancer in the one remaining kidney. And that, of course, as Lisa said, life happens, or had an accident where the kidney had to be removed. And if you only have one kidney, it puts you into trouble. But yeah, of course, it can be related to high blood pressure and diabetes arising, for example, in the rest of your life. But thankfully, it is not. It's not a very large group of people.
I'll just quickly just add on to that as a nephrologist. Obviously, we I always say to potential donors, you're going to get the most rigorous MOT possible. But from my perspective, I guess from my selfish perspective, the most toughest part of that MOT is to look at the individual's level of kidney function, to make an estimate as to will this individual be able to manage with what kidney function they will have left, which again, we're talking about ending up with something up to 80-85%. We're also looking at potential risk factors for kidney disease as well. So we're looking at those common things. You'll be screened for diabetes, for inflammatory kidney diseases, high blood pressure, etc., etc. So it's not just having a very tough look at what your level of kidney function is, but it's also thinking about what level of kidney function you will be left with for the rest of your future. But it's also looking at potential problems which can lead to kidney disease. So that all forms part of this this MOT, so to speak.
Thank you all. Just because we've returned to kidney function, there's a very specific question about a particular donor who donated some years ago, and their EGFR has been consistently 45 to 50, and would that be of concern to you, or should the donor be concerned about that?
So I'll quickly jump onto this, and I think this goes on to what Lisa mentioned earlier about kind of GFR and kind of the kind of how we make stages of kidney disease. I mean, if someone has a stable EGFR, and again, it very much depends on that individual's age and all their other factors, but a stable EGFR from a nephrologist perspective always gets thumbs up. But certainly with regards to the long-term surveillance, and I think that's one of the other things that perhaps we haven't touched upon, that we do offer kind of a surveillance program. We do wish to follow up all of our live donors, ideally in the hospital, and my live donor coordinator colleagues will run kind of an annual checkup where we encourage all of our living donors to come up, have their bloods done, urine samples sent off, have a blood pressure done. If they don't want to come all the way to the hospital and pay the extortionate parking, we will definitely recommend that they get that done with their GP. But we do recommend, obviously, there is an ongoing surveillance. But no, certainly from our perspective, that EGFR, if it's stable and other things are all fine, blood pressure, etc., we would not be concerned with that at all in the context of donation.
Thank you, Adnan. I think probably, unless there's any other burning questions, we'll start to draw it to a close now. There was a question that we had submitted before the webinar around how the waiting list is prioritised and about the kidney sharing scheme. We did a whole other webinar with Lisa Mumford of NHS Blood and Transplant about that subject, and I think that would probably answer those questions. Rather than going into that just now. And that's available on our website and on our YouTube channel, which I encourage people to have a look at, or our other webinars are all available on there. So do please subscribe. If you're watching this now live on YouTube after the fact, if you have any questions, obviously please do email Give a Kidney at info@giveakidney.org. And I think the other thing that we want to really stress is that Give a Kidney is here to support donors living donors going through the process, during the process and beyond. We can give you other donors to speak to who've been through the process, like Paul. And if you've got any questions that we haven't answered today, we can certainly go back to our team of experts who I'm sure would be very happy to respond beyond today's webinar. So thank you very much to everybody for joining us today. Thank you very much to our panel for giving up their very precious, I know, Saturday morning. As I said, please do check out our website at giveakidney.org or email us if you've got any more questions. But if not, then I will leave it there today and say thank you again.